Coming up on Need to Know, the shift in power soon coming to the Oval Office means a likely shift for health coverage if you signed up under the Affordable Care Act. Making sense of what repealing and replacing President Obama's health care law means for you. That's next. Also on the show, we'll learn about a Rochester pharmacy trying to break the barrier to health care access for refugees, low-income residents, and the disadvantaged. And the burnout rate for doctors is higher than any other profession. And what you may not realize is this impacts all of us. But local clinicians are working to dramatically change the issue by introducing a path to mindfulness. Don't miss this story. Need to Know starts right now. Americans continue to speculate about the forthcoming changes with the presidential transition. And one of those big question marks pertains to health care, in particular, the Affordable Care Act. So what's in store for President Obama's signature health care law, and how could this affect you? Joining me to break this all down is Sarah Liebschutz, Professor Emerita at SUNY Brockport. Ted Brown, Charles and Dale Phelps Professor of Public Health and Policy at the University of Rochester, and Trilby DeYoung, CEO of the Finger Lakes Health Agency Systems. Welcome. Finger Lakes Health Systems Agency. I got it. Thank you for being here. I appreciate it. So what happened after the election was really an interesting thing with the Affordable Care Act, and some described it as this healthcare stampede. The numbers of people that signed up for healthcare coverage skyrocketed, and a lot of questions were being asked, such as, what's going to happen to my coverage now that we have a new president who plans to repeal and change things? So I start with that question. I will give this to you first, Sarah. How long do we even know how long the current plans that we have right now will last?
I think that nothing is going to happen in a great hurry. I think even the bills that were passed by the Congress and vetoed by the president, there were 60 of them, provide for a 2-year transition period until replacement is completed. It may be longer than that. But I think people are absolutely right to sign up. The period goes through January 31st, and then we'll see what happens.
Well, we don't know the specific details, I should say, of President-elect Trump's game plan at this point. But when it comes to possible changes for the Affordable Care Act, I know we can't see into the future, but we know there are certain things. What will likely stay, and what could potentially go? And in terms of what could go, what do Republicans really give as this rationale for some of these changes?
Well, I would say that the Republicans would rather put more reliance on the marketplace, and that as President-elect Trump in particular hasn't been so comfortable with the idea of an exchange where the product that people are given some help to purchase is actually regulated so that it has some basic minimum coverage. I think we can expect, a few years out to see that consumers are given some help, but are expected to choose among a broader range of products that really don't have the kind of consumer protections in them that we see in the exchange today.
Any other things, Ted?
Well, about the exchange, I think one of the major changes that might come, and I agree that we're going to see some lag, because I think the Republicans are making a very good calculation that many of their base would be hurt if some of the changes went through right away, and in fact, they could not enact by the rules of Congress some of the changes they might like. Anything that has to do with budget, they have the majority in the Senate, 51, but to pass budget changes under reconciliation. But if they wanted more dramatic changes, such as to gut the pre-existing condition provision, that would require probably a 60-vote supermajority, because the Democrats will undoubtedly filibuster on that to prevent that from happening. And the Republicans would also calculate that they would hurt many of their own constituents. And I can give you numbers on that and estimates that have been coming forth. But one of the possibilities with exchanges is that the Republicans, Tom Price in particular, the incoming Secretary of HHS, might opt for a computer system, a marketplace that is driven, and as it is presently, looks the same in many ways, but doesn't simultaneously enroll people or scan to see if they might be eligible for Medicaid rather than one of the commercial plans. And that would be a significant change, in addition to losing some of the protections that are presently built into it.
Yeah.
I think it's important, in addition to the point that Trilby made, to think of this as an effort to devolve more responsibility to the states. I think that's a very signal part of the Republican psyche, if you will. Many states have taken advantage of waivers, that is, exceptions to the law, under the Affordable Care Act. And it's always been said that states are the laboratories of change for the nation. And I think Republicans, as well as Democrats, agree with that. I would also say that the most unpopular, in this public opinion polling, aspect of the Affordable Care Act is the mandate. Nobody seems to like the mandate.
Right.
Many other parts of the Affordable Care Act, like being able to get insurance if you have a medical history that normally would disqualify you, or keeping children or young adults on parents' policies up to the age of 26. These are very popular positions of the entire public and both parties. They're not about to be repealed.
I was going to say, those
But
are two things that-
the mandate is the problem.
Well, if I may
Yeah.
Sorry?
Go ahead. No, I'm just
comment
thinking.
on the mandate, there's one very important player in this who really would like to see the mandate, in fact, will demand it, and that's the insurance industry, because they cannot provide plans under the exchanges that in any way are viable if they don't have a significant number of enrollees who are young and healthy to compensate for, in their overall financial calculations, those older, sicker patients who will now be allowed to sign up. They want the mandate. It was an exchange. We will agree, in part of the negotiations that led up to the Affordable Care Act's passage in early 2010, we will agree to include pre-existing conditions as part of our new way of doing business if you can guarantee that we will have sufficient new customers to make this actuarially possible and that we can still come out ahead in profit terms. And even with those conditions, several major insurers have left the markets, Aetna and Humana most notably, and there might be more departures. I think the Republicans are very aware of not antagonizing the insurance industry, which is part of the political calculation as well.
So it's almost like this death spiral, because if you take away the mandate so that young and healthy people are not entering in, then you have older, sicker people, premiums just keep going up, and the whole thing becomes unsupportable.
That's right.
And I want to ask you about that. The Kaiser Family Foundation did an analysis on health insurance premium changes in 2017 and found that some states with the second lowest silver plans, we're talking about 40-year-old non-smokers, and in some cities the premiums increased up to 145%, and in some it decreased by 4%. So I want to know, how does that happen, and are there chances here in New York State that we could see a type of increase like that?
Well, I think you have to realize, first of all, it's the states that regulate rates, premiums, and financial viability, so that insurance companies can meet claims, can respond appropriately to claims.
In terms of, I'm sorry to interrupt, buying across state lines, though, how does that
That's
affect
a different thing.
Okay.
That does not occur now. Insurance companies are regulated in the state where they do business. If you remove this, and I think the president-elect has supported this, buying insurance across state lines, but that has a downside too. Maybe we want to talk a little bit.
What would you say? Yeah.
No, that has a serious downside along the same lines I was suggesting before, because imagine someone is living in New York State and is a younger, healthier person who is paying whatever the rates are negotiated on the exchange. He then has the opportunity, if this goes through, to have a purchase of insurance across state lines, a plan that's based in, let's say, Kansas, in which there's very minimal regulation. The New York regulations will stipulate that all the plans that are sold in the exchange have certain fundamental conditions and characteristics, et cetera. So they cost a little more because they cover lots of things. This younger, healthier person says, well, I can get a much better deal, meet the obligation of having to get insurance by buying my insurance in a company that's based in Kansas. And that would have the same effect of leaving the older, less healthy people in New York State because of its regulations and guaranteeing those people get covered, and that leads to the same spiral that will drive insurers out of the market ultimately, or have them charge such high premium increases that it's unsustainable.
I think overall what you see is if you start to take pieces out of the Affordable Care Act, the whole thing can come crumbling down.
All right, well, very helpful information. I thank you to all of you for weighing in on this topic. You have until January 31st to enroll in or change your health care plan for 2017. To sign up for coverage, go to nystateofhealth.ny.gov. Well, the U.S. Department of Health and Human Services has been tracking disparities in health care across the country. And as WXXI's Sasha Ann Simons has learned, local health professionals are trying to fill in some of the gaps. Sasha?
That's right, Helen. According to the Agency for Healthcare Research and Quality, access and disparities in access to healthcare are the primary reasons the U.S. health system falls behind other countries. In other words, too many people don't have full access to essential health services. I spent some time over the last few weeks meeting health professionals in Rochester trying to break that barrier for people who live in the city. Here's more. In Rochester's refugee community, the lack of English language skills becomes even more prevalent when it comes to health issues.
Not bad. About 136/90. Are you taking your medication?
Sarah Miner is a community health nurse who has been doing home care for the last 6 years. About 4 years ago, she connected with Refugees Helping Refugees, an agency supporting people who've had to leave their home country by putting people who have been through the same experiences at the front line. Miner began working with the group, offering the medical expertise they couldn't. She recalls a past home visit with an elderly woman from Somalia.
She has this bag with medications in it, but she told us she doesn't know what they are.
Chronic illness is often a new concept for refugees.
An acute illness, you take a medication, you take it, the illness ends. They understand that. But this idea that you have an illness that you have to take medications, perhaps for the rest of your life, that's very new to them.
According to the latest National Healthcare Disparities Report published by the Health Department in 2015, despite improvements, disparities in access to healthcare persist, especially among people in poor households, Hispanic people, and African Americans. 69-year-old Sarah Laza admits her English is not the best, but she has a good understanding of the medication that's been prescribed for her to take every day.
I need my medicine. I don't play with my medicine.
The Puerto Rican woman suffered a cardiac arrest 6 years ago, and there were 2 heart attacks in the years before that.
I have 5 for the blood pressure, 2 for my heart, my insulin.
Laza is organizing next week's set of pills in a package she gets from Saratoga Pharmacy in downtown Rochester, and credits the pharmacy's easy-to-use packaging system and multilingual staff for helping to maintain her health.
Sometimes the doctor changed my medicine, and I don't know how to use it. They explain, they call me, and they say this, like that, in Spanish.
Saratoga Pharmacy has stood at Lyle and Saratoga Avenues for decades. But now, since a takeover in 2015 by its third owner, the local pharmacy is becoming a staple in the community.
All right, let me check for you.
We wanted somebody here who speaks the native language. So I started hiring people who speaks their own language. We have all multicultural employees here, like Nepali. We have Somali. We have Burmese.
And in addition to Spanish-speaking staff helping customers like Laza, pharmacists, technicians, and clerks also speak Korean, Greek, and Hindi. CEO Usha Ramadagu says she immediately saw the challenges for people living in the city. Language was one, access to reliable, cost-effective transportation was another, which drove Ramadagu to offer free medication delivery nearly round the clock.
The third one is compliance. 58% of the population, they do the errors in taking the medication, and that end up in chronic conditions.
Through the use of medication therapy management, Saratoga Pharmacy acts as the ultimate go-between for doctors and their patients. Pharmacists counsel people about their medications and coordinate with other pharmacies to ease the customer's burden. The effort, Ramadagu says, also helps reduce hospital readmissions. The effects of a sudden hip replacement surgery prompted Diane Moultrie to call Saratoga Pharmacy last year. Having limited ability to walk, Moultrie relies heavily on their delivery service.
Being in town, I live alone and I don't have any family in Rochester. There was nobody to go get my medicine for me.
The customized pill packaging, marking daily and time of day dosages, has helped Moultrie stay on top of her health.
You know, as you get older, it's like your memory doesn't work the way it used to.
Yeah, and we were actually just talking.
At a time when new leadership takes over in Washington, the future of healthcare in America is unknown. Medicare and the Affordable Care Act could undergo major changes or be replaced entirely. Miner says she's frightened by the possibilities, but remains hopeful for the immigrants in her care.
We have to have an efficient and safe delivery of health care for all people in this country.
Sasha Ann Simons, WXXI News.
In other health news, there is a problem in our country that some are calling a public health crisis. It's physician burnout. And according to reports, the issue is only getting worse. But something called mindfulness, which is the effort to continuously remain present and aware, has proven to be a game changer for clinicians. I recently spoke with doctors Ron Epstein and Mick Krasner of the University of Rochester's Mindful Practice. They, along with their colleagues, have been leading research and training programs for health professionals to enhance their self-awareness, improve relationships with patients, and even advance the quality of care they offer. Take a look.
How do you make the case for mindfulness, specifically when it comes to clinicians? Because this is a high burnout job. This is a job with a lot of demands, stress, and pressure. And I would think that there might be a little pushback when you approach some physicians or nurse practitioners, considering the demands that they're trying to meet, and to say to them, why don't you take time away from your job to learn this practice? How do you make the case? How do you pitch it? And I'll give that to you first, Ron.
I think everyone wants to be at their best. And part of mindfulness has to do with paying attention in a particular way and being present. So think about a surgeon in the operating room. You don't want them to be distracted. You want them to notice when things are going wrong before anyone else so they can act quickly. Think about a psychiatrist. You want them to be present so they can hear signs of distress. Think about a family physician who is dealing with 3 or 4 medical problems at a time and really needs to pay attention to try to figure out what's most important. And the second piece really has to do with curiosity, because mindfulness is partially about curiosity, really an interest in people, because if you don't have an interest in people and you're in medicine, first of all, you're not going to be very happy, and also your patients really won't feel heard. And the third thing has to do with presence. And when you ask patients what they like about their doctor, they'll often say something like, he or she was really there for me. And that kind of presence really matters to patients.
So, Mick, for those who are watching right now and they're saying, I just don't get it. I don't get how a doctor who is practicing mindfulness, I don't know what that means for me. When I'm coming into the hospital or to meet with them and I'm dealing with X number of health-related issues, how does that better serve me? So what would you say, and what would you say to this person, and does a more self-aware and attentive clinician result in better treatment, a more thorough diagnosis, and so on?
Well, I think what a patient would notice is that, as Ron had just mentioned, that their physician is actually listening, is actually present, is actually there. Probably the most central quality that we use as clinicians is our capacity to pay attention, to be aware, to use awareness of what we're hearing, but also the awareness of what we're feeling, what we're noticing in ourselves, what's being triggered in us, so that will help us lean into the problem that's being presented with us and make a diagnosis. So I think from a patient's point of view, they would just notice this person is really there, is listening, is taking into account, and really understands me, really has empathy, a sense of where I'm coming from, and from that makes me feel like I'm being well cared for. There is a clear connection between the well-being, let's say, of a physician and the quality of care that physician delivers. That's been established. And now we're seeing that the actual quality of caring, the sense of being cared for from the patient's point of view, is also part of that equation. So that to the extent that mindfulness can lead to practitioners and physicians that are better off, that feel better about what they're doing, as Rhonda said, that are into what they're doing and present with it, then quality of care and quality of caring will improve as well.
Well, the two of you, with a team of colleagues at the University of Rochester, you designed this year-long program in mindful practice. This is back in 2007 to 2008, and this was for experienced primary care physicians. And I understand that some of the results from this year-long study blew you away, in particular when it comes to physician well-being and burnout. So if you can jump in, just tell me, what did you find? I'm curious.
Well, the part about well-being and burnout actually didn't surprise me at all, because we know that mindfulness interventions do that for everybody. The two things that surprised me was that their care for patients changed. They became more empathic, more engaged with patients, and also their personalities changed. We did personality inventories and found that they were just fundamentally more attentive and also much less likely to be thrown off balance, that they had a much greater sense of emotional stability. And clearly in clinical practice, it's an important thing, but it's also important for one individually, because when you have a difficult situation, you don't want to really be knocked off balance.
Well, you hosted this 4-day workshop this past fall. This was attended by medical practitioners from around the world, and we stopped by on day 3 of this mindful practice workshop, and we had a chance to talk to some of the participants. And in this video that we'll see, they explain just how effective really cultivating and sustaining a mindful practice can be. So we'll take a look.
It's a very serious national problem that our physicians and nurse practitioners and other providers, psychologists, are taking care of the suffering of patients and yet under a lot of stress themselves.
Allowing anything in your field of awareness to be worthy of your attention.
These guys have developed a program which has been studied, it's been written up in the Journal of the American Medical Association, on physician empathy, reducing burnout. That's what got me up here.
That decision to show up is really one of great courage, and I just want to name that and acknowledge it.
There is, I think, a general anxiety particularly among doctors, about what this is, about being open to something like this, about being vulnerable and experiencing something which they're not familiar with, which is a little open-ended and a little unsure.
Sometimes you might think of that it's about teaching meditation, and although there's a component of mindfulness and meditation, much of the course is actually how can you be attentive, compassionate, present.
What happens on the cushion is one thing, but in your everyday life, when you're in the thick of things with patients or with your family, that's really where the work is, to live more mindfully, to work more mindfully.
A simple thing is find space every day, and it could be as simple as 30 seconds or longer. So time need not be a barrier, but that you can actually pause and check in with yourself and just see how you're doing. Just building in a simple catching your breath and a pause is invaluable.
Just bringing your attention and awareness back to the single thing, the breath.
If you're going in with a patient, the patient is there because there is some level of suffering. And we need to honor that and take a moment to get ourselves ready to go in being fully present. And that's a big challenge. But here, what we've been learning this week is to be able to be fully present, both with our colleagues, our patients, and ourselves. A big message of this workshop has been we need to have more awareness of ourselves.
From what we've discussed thus far, and what we heard in the video, the benefits of this practice seem endless. But how do you actually do it, right? I know there are several layers to it, and it's about an experience, much more than listing off what it means to be mindful. But how do you practice it? And how, as we heard from our last interview subject, how do you learn to go in and be present? Mick?
Yeah, well, we try to make it very practical and very real. We try to give suggestions, and we practice things that one can do in the moment, in the office, in the practice of medicine. For example, as you enter a new patient's exam room and you're ready to begin on a new encounter, just taking a moment, stopping, taking a breath, observing what's actually happening, what you're about to do, and then proceeding. Very simple, short reminders of how to be more present, how to work with the patient and notice what's coming up. And it doesn't mean that the goal is to train yourself to not have stress, to not feel anxious or worried. It's actually about how to bring whatever is present for you into the exam room, and that it becomes part of that encounter. And so it's not that we need to create a rarefied state of being, that it actually, just being in the state that we're in and being aware of it allows us, rather than to react to it automatically and being on automatic pilot, allows us to respond with a little greater degree of wisdom, a greater degree of presence with our patients. Yeah.
When we were there, a number of the clinicians we spoke to said, we are armed and ready, to go back home and to put this into practice and to teach others how to do it. But they said, but that's kind of the challenge too, is finding the time to do that. And then how do you, I guess I would think another challenge might be, how do you continue to practice this and sustain this given the high demands of the job? I mean, how do you tell people to try to do that? That's hard.
It is. One thing that wasn't in the video was that we do a lot of exercises in pairs and dialogue, and trying to help people listen deeply, listen deeply to others, and listen deeply to themselves. And in those dialogues, we touch on really potent themes in medicine, like when you make a mistake, or when you really like a patient, or when you really don't like a patient, or when you lose a patient, when someone dies. And I think by virtue of bringing those real-life themes into this frame of mindfulness, then people can then say, well, I'm going back to my practice, I'm an oncologist, I'm going to see patients who are very sick, how am I going to be with them? So medicine's about being with people. Most of your time you're really spending interacting with people who are suffering. And so we bring that experience into the workshops to help people be better prepared.
Well, very important work that both of you are doing, and I appreciate you letting us be a part of it, and I also thank you for your time here today. Thank you.
Thank you.
Thank you.
Dr. Ron Epstein has written a new book about the power of mindfulness in medical practice. You can pre-order your copy of Attending: Medicine, Mindfulness, and Humanity at Amazon.com. And that's it for this edition of Need to Know, Rochester's News Magazine. I'm your host, Helen Bianduti-Hofer. Thank you for joining me tonight, throughout the weekend, and online at WXXInews.org. I will see you next week.